Hello.
Hello, Ashwin.
Yes, sir. Yes, sir.
Can we start?
Yes, sir. Can we start?
It's not audible clearly. The sound noise is there, Ashwin.
Hello, sir. Now. Hello.
Hello.
Yes, sir. Now you are audible, sir. Now I'm audible.
Okay, it's noisy, but okay, it's okay. I mean,
Okay.
shall I start? Is it fine?
Yes, sir. You can, sir.
Anyone is missing? Any of the participants? Hello, everyone. Good evening. I'm Dr. Anand Ganor, Veterinary Surgeon, Anugrah Hospital, Vijaypur, Karnataka. Ashwin, please, you can mute your sound, please. Guys, hello.
Yeah, we can hear.
It's a privilege to be part of this session. We all know that it's IC, that is Combined Procedures in Ophthalmology. We have some energetic people with me. Dr. Anuj, Dr. Madhu, Dr. Manjunath, Dr. Tanushri, Dr. Puneet, myself, and Dr. Shivkumar. I'll be giving details of each of these speakers at the time when their talks are going to start. And for this session, we have chairman as Dr. Mahesh Kumar and co-chairman as Dr. Purna Chandra. Yeah, we are also very thankful to organizing committee and chairman scientific committee for allowing all of us to get together here for this session. It's really a privilege. And talking about the topic that we're going to discuss today, combined procedures in ophthalmology. It's a newer concept that has developed in the recent last decade or so. Previously, we all know that cataract surgeries such as SICS or phaco used to be done separately because rehabilitation recovery used to take some time and all. With the advances of MICS and other microsurgical procedures like MIVS and all, where the integrity of the eyeball is maintained, now the recent concept is trying to combine cataract surgeries with that of additional one more procedure. For example, cataract surgery with vitreoretinal surgeries. So basically, the intention is to make sure that both doctor and patient is benefited. For the doctor, it's going to be less frequency of visit by the patient as well as faster recovery. Again, for the patient, it is beneficial because cost effectivity is going to be, and also he's going to be recovery is going to have visual recovery a bit early, and rehabilitation will be better. Anesthesia frequency will be less. So all in all, it's going to be good. Of course, there are some prerequisites that needs to be followed. Like for doctor, he has to be perfect in both the procedures. Like if he's trying a cataract surgery, phaco, he has to be very good. In addition to that, the procedure that you want to combine, in that also he has to be good. So once he is good in both the parts, he can combine them, and again he can develop his skills. So all in all, we have a good concept, good session here. So let me start the session with our first talk by our Dr. Anuj Ponappa. Dr. Ponappa is from Kodagu. He's the consultant as well as the owner of Lopamudra Eye Care Kushal Nagar Kodagu Hospital. He's done his MS Ophthal from RGHS and also fellowship from Arvind Eye Hospital, Madurai. He's been excellent speaker all throughout, and he's done some publications as well as presentations in conferences. Over to you, Dr. Ponappa. Ashwin, please start the video.
Good evening, everyone. I'll be talking about phacotrabeculectomy, a surgeon's perspective. I thank the organizers for giving me this opportunity, where I can share a bit of tips and tricks and decision-making processes when it comes to phacotrabeculectomy. So the first question which everybody gets is when to do what, but again, there's no clear consensus. So we'll take evidence-based approach there. we have included 36 RCTs, 7 non-RCTs, and 38 cohort studies to arrive at interferon. So now these studies which we've gone through, what does that indicate? Now with weak evidence, it indicates that phacoemulsification decreases IOP by 2 to 4 millimeters, but then the efficacy of which normally drops down, and by 5 years time, the patients will be back on anti-glaucoma medications. With moderate evidence, what does that indicate? That a 2-site surgery provides better IOP control than single-site surgery. And strong evidence indicates that trabeculectomy alone results in better IOP control than when you're comparing it to combined surgery. So with this, what do we infer? If we have a mild to moderate glaucoma which is under control, go ahead with phacoemulsification. And then again, suppose you have advanced glaucomatous optic neuropathy, wherein your primary motive is to save the optic nerve, and then cataract is only mild to moderate. You go ahead with trabeculectomy followed by cataract surgery. Now, when you have uncontrolled glaucoma with cataract, and uncontrolled glaucoma which requires 2 or greater than 2 medications. When I say 2, always there's only 2 medications which you'll have to think about. One is an aqueous suppressant, another is a prostaglandin analog. Because if your pressures don't come down with these 2 drugs, it will not come down with the other drugs too. So then you can opt for a combined surgery. Now, whenever this patient comes to you, basically the patient is really old age patient. So basically many of these conditions, that is glaucoma and cataract, will be coexisting. And sometimes the patient walks to your OPD and then you'll see there is cataract. The patient also presumes it's cataract. But when you do the examination, you find out there is an underlying case of glaucoma. Then when you're handling such cases or going ahead with combined surgeries, trabeculectomy with cataract in patients, you'll have to take some time off and explain to the patient to have realistic outcomes. Because repeatedly you'll have to tell the patient that the surgical correction of cataract will not rehabilitate the visual loss which has occurred due to glaucoma. Very important is, I think as a doctor, instead of sending the patient to the counselor, you will have to go that extra mile and take an informed consent from the patient. Now, pre-op, what are the things you look for? First is you'll always look for the history of past medications. Have they been on treatment for glaucoma? Review the old records and all these things. And again comes the slit lamp examination. During slit lamp examination, you'll have to look for the conjunctival status. Is it virgin conjunctiva or is it hyperemic? Because most of these conjunctiva of people who are on chronic medications will be hyperemic because of chronic usage where BKC is the culprit. Then look at the pupil status. Is there any PXF? Because intra-op, you will find that the zonules are weak, and then you'll have to change the plan of action. Then you look at the pupil, it doesn't dilate, you'll have to use VHEX. Look at the angle, is it open, closed? Look at the lens status to find out if it's mild, moderate, severe cataract. Look at the glaucoma, is it mild, moderate, or severe again? And most importantly, don't forget evaluation of the retina, because sometimes there's a macular pathology and we are so fixed and focused on looking at the glaucoma part that we overlook the retinal pathology. Now, surgical options, like I said, you have 3 options. And suppose this is a special considerations which I'll give with an Indian scenario, because affordability, since the affordability will be less, we'll see a lot of patients who are non-compliant to medication. So combined is preferable. Again, since poor access to medical care, the patient might not make repeated visits to the doctor, might not, take the proper medication. So combined scores 1 point extra there. Then third thing is education and social economic conditions, because of that, what really happens is patient might not understand the severity of the condition, and also if you go with a single procedure, the patient might think this is it and might not turn up for the secondary procedure. So that goes in favor of combined surgery. So advantages is it restores vision promptly, the single procedure, decrease glaucoma medications, and after the operation, the doctor will be able to have a better assessment and look at the optic nerve and visual fields. And like we also know that doing trabeculectomy always hastens the process of glaucoma progression. So few tips when it comes to surgical process per se. Always the choice is clear corneal phaco with trab, and always respect the conjunctiva. Use always non-tooth forceps. And suppose when you're handling, even with when you're going ahead with the trap part, use corneal traction sutures and so that you're not causing undue trauma to the conjunctiva. And the flap, whichever you take for the trap, it will be half to 2/3 of the thickness, so you don't have buttonholing. Here you can see, and once you do a conjunctival peritomy, just dissect under the tenons, go as posteriorly as possible and laterally, not just like SICS where you just make a small conjunctival peritomy and progress with the surgery. And here, on application of mitomycin C, you'll have to place the pledgets for 2 minutes and then take it out. And also at that time, be very careful of the conjunctival edges. Once you do all of this and trap procedure, like I said, you make a flap, don't enter the AC, just make the flap after you put the mitomycin C, finish your phaco, and then once the phaco is done and the IOL is implanted, go ahead, enter the AC, then continue with the trabeculectomy procedure, which you have to do. After which you place sutures. Once you place the sutures, preferably like in an Indian scenario, if you don't have access to green lasers, go ahead with your releasable sutures, because on post-op day, it has a better outcome, and you can always titrate the IOP depending on releasing the sutures or not. Now, again, an important question occurs, which is the choice of IOL I would use if I was treating glaucoma as in a combined? Aspheric is better because, like we know, even in early stages of glaucoma, the contrast sensitivity decreases. So aspheric is always better. But in special conditions, say veillate spherical, wherein there's PXF, where there is a chance of decentration. So what happens is the spherical aberrations increase when there's decentration of an aspheric lens. A multifocal is not recommended because initially as we know, the contrast sensitivity is less with multifocals, and since glaucoma is a progressing disease, and with multifocal, what we are doing is we are splitting the foci of light into 3 or 2 zones. So multifocal initially in the early stages, some people might opt to put it, but in the long run, since the glaucoma patient will always be a patient, it will be problematic. In the post-op consideration, they'll have longer post-op medications. IOP spikes in combined is lesser as compared to cataract extraction, which goes towards going ahead with combined when the need arises. And like I said, again, whenever this is an important point, when you use releasable sutures, kindly use laser suture lysis or releasable sutures, and always keep the sutures tight of your flap. You can, for the flap, you can put 1 suture, which is apical, or 3 sutures, or you can use 2 releasables or single releasable, but always see to it that the flap is sutured tightly. So in the post-op days, anywhere after 1 week, we can either remove those sutures or lyse those sutures. The take-home message here is always and always choose the right patient. Very important after explanation of all the conditions. If the patient is okay with it, okay with going ahead with the procedure, you're spoken to him. I would say, in fact, in your consultation, when you talk to the patient, please do take extra 5 to 10 minutes just to explain these things to the patient and choose the right procedure. Does the patient really require combined? Go ahead with it if it's combined required. Always respect the conjunctiva. Be it you're using pterygium or everything, I always say respect the superior conjunctiva. And always glaucoma treatment involves a joint decision and a dialogue between the patient and the doctor. And the ultimate goal of any combined procedures or anything is, especially in a glaucoma patient, is improvement of quality of life. So once we do a combined procedure, the number of drops which the patient uses comes down dramatically, and the BKC side effects and all of these come down, and patient will be a not so happy patient, but patient's quality of life will be much better than with all the medications. Thank you.
That was a nice presentation, Dr. Panappa.
Thank you,
Dr. Panappa?
Anand. Can you hear me? Yeah, I can hear you.
I just wanted to have some queries related to patient coming to OPD, for example, if patient is having significant cataract with silicone oil inside, and again with raised IOP. So how are you going to manage this kind of cases?
See, Dr. Anand, what I would go ahead with first and foremost would be controlling of the IOP, because at the end we know we want to save the optic nerve. So how do we go ahead with this? Number one is, suppose there's the silicone oil inside. I would first go ahead with check the IOP, do a gonio, see what is causing it basically. Is there emulsified oil, or is there a secondary angle closure? What is the mechanism? Number one. Number two is, obviously I would send it back to a vitreoretinal surgeon like you to take out the oil, number one, and see if the inferior PI has been done, importantly, because otherwise the mechanism initially will be pupillary block. And after that, if there's emulsified oil, there will be this thing. But again, medically, how good the control will be, since all the conjunctiva has been handled, then the options for you once would be a glaucoma drainage device, which would go on a long way. And yes, cataract is something I would have handled it later on once the IOP is under reasonable control.
Right. What is your preferred anti-glaucoma medication in vitrectomized eyes?
See, preferably, I think vitrectomized eye, around, I think 10% of them actually go in for glaucoma. Even the exact mechanism is not known. And I think some studies probably show, I think there's oxygen and free radical damage, which happens when oxygen comes from the posterior chamber into and causes trabecular damage. Again, the concept there is, have you used oils, or have you done any scleral buckling beyond it? There is some bit of confusion. Some people think, some of them really don't use prostaglandins at that point, but that is not so, because I use prostaglandins. The reason being, there are some specific studies which show the BKC which causes the CME problems. And again, the same thing here also, medically, if they are not controlled, whenever, again, I want to stress the point, whenever we opt for a combined surgery, there are only two drops which you look for. You put something like a timolol or beta blocker, which suppresses aqueous, and then you use something like a prostaglandin, which increases the outflow. If these two don't work, we using carbonic anhydrase inhibitor and all the other things will not probably work. Then you're left with surgical options only. Surgical options, I think Arvind aqueous drainage implant is doing good. So yeah, Barveld.
Right. How exactly two-side phaco trabs are going to be beneficial?
See, I think I mentioned, it's very moderate evidence. Now, at the end of it, I'll start with why some people prefer one site. I do two site definitely. One site, apparently, one study indicates it saves 11 minutes of your time. There is a study done there, but I think if I'm treating a glaucoma patient, I wouldn't really be thinking about 11 minutes. Important things is two different sites. Yes, 2 to 3 millimeter decrease is shown in some studies, but none of them are conclusive. So this is an evolving science. But one good aspect here is, when you're doing your phaco, your AC is kept taut because you're not entered to the top point. And second point is, when you're applying something like mitomycin C, you want that area not to heal. So you're okay with a two site. And again, some patients are with deep set sockets. I always prefer to do the phaco sitting on the temporal side, and the superior will be, there for the trab. And I can, in fact, whenever you place your flaps, you can also place it not exactly superiorly, something little bit of superior nasal, little bit of superior temporal, so that in case the need arises, you have another space to pick up one more flap in the future time for a resurgery. And of course, now with drainage devices, things have changed. But in a tier 2, tier 3 place, you ask me as a glaucoma person, would I put a drainage device? No, it is. I would still put it only if I'm in a multidisciplinary approach. I would stick with trab and cataract only in this case, because what happens is, managing the post-op in a single practice or a dual practice setup becomes extremely difficult and important in these cases.
Great. Thank you, Parampa. It's been really enlightening. Thank you very much.
Thank you.
I think we have our next speaker with us, Dr. Madhu Ganor. Let me give a brief introduction about her. Dr. Madhu Ganor, she has done her MS from Siddhartha Medical College, RJHS, and her fellowship from Anugrah Hospital. She is cornea refractive and phaco surgeon at Anugrah Hospital. She has also done a fellowship in LASIK, and she is in charge of the LASIK related faculty here, as well as we have the topic is corneal tear with cataract, tips and tricks. Over to you, Dr. Madhu. Ashwin, please start the video.
Hello everyone. At the outset, I would like to thank Dr. Alit Kumar sir and Dr. Anand Ganor for giving me this opportunity. Let me share my screen with you all. So the topic given for me is corneal tear with a cataract, tips and tricks. I'll be covering this topic under the following headings. Coming on to introduction, ocular trauma is nothing but a damage or a trauma inflicted to eye by external means. Here both surface injuries and intraocular injuries occur. Soft tissues and bony structures around eye may be involved here. Trauma is considered to be one of the most important cause for unilateral loss of vision, particularly in developing countries, of which 90% are usually preventable. Most of these injuries usually occur at younger age group, and more common is a pediatric group. Coming on to the classification of ocular injuries, this is the classification, the details of which I'll not go into. Mainly I'll be covering here is a penetrating injury, which is nothing but the trauma caused by sharp pointed objects like pencils, knives, glass, or any objects with sharp edges. Effects mainly include laceration of conjunctiva and cornea, vitreous hemorrhage, globe rupture, scarring, traumatic cataract, glaucoma, and retained intraocular foreign bodies. One has to perform thorough examination of an eye to know the extent of corneal, anterior chamber, and ocular injury. I'll be mainly covering here is the corneal tear. If the corneal tear is very large and the AC is collapsed, then wound has to be sutured. This is a slide showing a corneal tear where there is a linear corneal tear with collapsed AC and traumatic cataract. Pupil has to be examined for size, shape, and light reflex. If there is a peaked teardrop shaped pupil or irregular pupil, it indicates a full thickness tear with iris prolapse. We have to avoid all sort of pressure around the eye to prevent extrusion of intraocular contents. Post-traumatic endophthalmitis is very common if there is a retained intraocular foreign body. This is a slide showing there is a limbal tear where there is a prolapse of the uveal tissue with irregular pupil, and here there is a linear corneal tear with the traumatic cataract. Again, here you can see there is again a V-shaped corneal tear with the traumatic cataract. In order to suture the corneal tear, we usually prefer general anesthesia because peribulbar anesthesia is contraindicated in such cases because it causes increase in intraocular and intraorbital pressure, which might lead to the extrusion of intraocular contents. The aim of suturing should be to maintain the watertight wound with the least scarring and to maintain the normal contour of the cornea. If you think that the wound is less stable, you can inject the viscoelastic substance either through the wound or by making a side-port incision. Corneal suture should be such that it has to be 90 to 95% depth of the stoma, 1.5 millimeter in length, and for equal depth on each side. This is the correct way of suturing, where you can see the suturing is equidistant from the margins. If you place a shallow sutures, then there will be internal wound gaping. Full thickness sutures may cause a conduit for the microbial invasion. Sutures of unequal depth and sutures of unequal length create a wound overriding. For sharp lacerations, we have to place equidistant sutures with respect to the internal aspect of a wound to achieve a good apposition. If there is a long linear tear, then involving the visual axis, then suturing should be done in such a way that at the visual axis, the suture should be short. This is the Rose-His technique where sutures at the periphery are longer and placed closer when compared to the central where it is shorter and the widely placed. If there is a corneoscleral or a limbal tear, one has to address the limbus first. Apposition of a limbal tear should be done first to maintain the anatomical landmark, and then other structures can be sutured. This is a picture showing the traumatic cataract. Next, I'll be covering this thing where you can see there is a corneal tear has been sutured and traumatic cataract. Addressing the traumatic cataract surgery at the initial stage depends upon the clinical context given and also depends upon the surgeon's choice. If visualization is good and everything is fine, you can go ahead and do the cataract extraction at the same settings. If visualization is poor, then you have to defer the cataract surgery. So there are various types of traumatic cataract like total cataract, membranous cataract, or there might be a white, soft, fluffy cataract. There is a ruptured anterior capsule and the loose cortex in the anterior chamber, or roseate cataract, which is usually seen in the blunt trauma. In trauma, there occurs a damage to the lens fibers where there is a rupture of a lens capsule, leading to the influx of aqueous humor and hydration of lens fibers, which finally causes opacification. There are usually three options for surgery, like either you can close the corneal tear and defer the cataract removal for later, close the corneal tear and remove the cataract and leave the eye phakic, or close the tear, remove the cataract, and you can place the IOL depending upon the situation. As I already told, this decision is left up to the surgeon's judgment given the specific clinical situation. In very few cases, you can do both the surgery in same settings. Whether to implant or IOL or not, it again depends if there is a high chance of infection, then IOL placement has to be done at the later date. If vitreous is involved along with the lens remnants, then it has to be best addressed in the initial surgery itself. And if the lens is cataractous and visualization is good, lens may be removed in the primary operation. One of the most important problem what we face during the cataract surgery is IOL calculation, because a traumatized cornea compromises the calculation because we do not get the accurate K readings. Either you have to do the IOL calculation of the other eye, or we have to take it as to be a 44D, considering it to be the average value. After suturing the wound and once the AC is formed, you have to inject the tryptophan blue to know the anterior capsule status. If it is non-ruptured and well, then you can do the standard CCC. But we have to handle it very gentle to avoid the stress on the zonules, and running of rhexis has to be avoided. If there is a ruptured anterior capsule, that is in case of ruptured anterior capsule, usually the cataract occurs within a few hours or even a minutes. And in such cases, CCC is usually not complete. And if there is small flap is left behind or something, you can cut it with the veneers in order to avoid pulling in the phacoemulsification, handpiece or eye tip. This is a picture showing that ruptured anterior capsule with cortical matter into the AC. If you suspect zonular weakness or dialysis, capsular bag hooks can be placed to secure the bag. CTR are placed if there is a large dialysis, but this is avoided in case of if CCC is not possible or posterior capsule is ruptured. Coming on to the cataract extraction, if it is a pure traumatic cataract without senile component, the loose cortex can be easily aspirated with the eye tip, or you can you also use the Simcoe cannula to aspirate the soft cataract. If there is a vitreous prolapse, it has to be swept back into the anterior chamber through the side port, and anterior vitrectomy has to be done. Or else it might cause the retinal detachment if vitreous is pulled in the handpiece or an eye tip. And vitreous should not be pulled out through the wound with a sponge. If there is a hyphema, it has to be washed out immediately. During cataract extraction, usually there occurs a spontaneous bleeding. To control that, you have to use the dispersive viscoelastic as a tamponade, or intracameral epinephrine can be injected to cause vasoconstriction. Whether to place our IOL or not, again, it depends upon the clinical context. If visualization is poor, place the IOL later. If bag is complete, you can put the single piece IOL. If bag is ruptured and anterior capsule is fine, if you feel that support is present, you can go ahead and put 3-piece IOL. Usually anterior chamber lenses are avoided in such cases. After completion of surgery, intracameral antibiotic has to be injected, and you have to assess for the leakage of the wound, of both surgical wound as well as the corneal tear wound. If it is difficult to assess the sutured wound because of edema, then you can inject the air. If there is escape of air, you can again suture it. Post-operatively, you have to give the antibiotics, steroids, and cycloplegics to reduce the post-operative inflammation. This is a video where you can see there is a corneal tear with a traumatic cataract. First, we have to address the corneal tear. Then we have to suture it. Once the AC is well formed, then you can go ahead and do the cataract extraction. Here the visualization is good. CCC is done here and loose cortical matter is completely extracted. Then place the intraocular bag IOL, and AC is well formed at the end. Finally, to conclude, ocular trauma is a blow to both physical and psychological state of patient and family members. Medical legal aspects of injury and documentation has to be maintained properly. Meticulously planned and executed management go a long way in improving the long-term prognosis, visual prognosis. Active participation of patient and relatives in management is very much important towards visual rehabilitation. The decision of combined or sequential surgery is left to surgeon's judgment given the specific clinical situation. When combined surgery done, it obviates the additional operative and anesthetic risk while affording more timely visual rehabilitation. Thank you.
Dr. Madhu, that was a really nice presentation, and very nice to show the video also. We just wanted to have a query about the preferred anesthesia that you want to have when you go for corneal tear repair.
Yeah, thank you, Dr. Anand. Yeah, as I already told you, like we usually give general anesthesia, but if your setup is such that if there is like everywhere GA is not available, so in such cases you can give either a facial block, so it minimizes the occlusion, like eyelid occlusion. If usually if you give the peribulbar block, there is a risk of extrusion of contents. So most of the times we avoid the peribulbar block, especially if it is a large tear. In such cases, as I already told you, you can give the facial block, or also you can give the posterior subtendon injection. And if you're like if you have to handle the iris tissue and all, like after giving these blocks, you can give intracameral anesthetic injections. So like some amount of patient will have some amount of comfort and pain will be reduced. Or intravenous sedation also you can give.
How about the B scan?
Yeah, that's what. Usually avoid the B scan because the eye is very soft and there is a corneal tear. So when we do the B scan, we have to apply the pressure on the globe. So there is again a risk of extrusion of the contents, and even there is a high risk of an infection also. So B scan is usually avoided. So because of this, in case of corneal tear, it's very important to counsel the patient. Counseling plays a very important role here. We have to explain the patient regarding the need of the second surgery, and like a risk of any retinal or any other complication might happen in the later date, risk of endophthalmitis. Everything should be explained to the patient, and informed consent has to be taken properly. So then only, like even if in the later day, if anything is problem other than this thing, then like everything will be in the written document, and we can show the patient that such and things are there, and later date we can do the B scan once the globe is formed.
Thank you,
Yeah.
Thank you, Dr. Madhu. Anyone else is having any doubts?
Yes, sir. I have one question for all the speakers. So, like, I had, can you hear me? Am I audible?
Yeah,
Yeah.
Puneet, yeah, go ahead.
Yeah. So, like, I had two cases of corneal tear. Like, I had one was trauma with the this thing with the vegetative matter. So, I injected ozol also at the time of primary repair. And the other one was with metallic piece, but there was no IOFB. Both of them developed late onset fungal end off after like 3 weeks of the repair. One didn't come back to me for follow-up. The other one I took up for vitrectomy and is doing well. So, like, what is your experience or opinion on like whether should we give ozol and oral antifungals for all to be on the safer side, or like, I mean, based on your experience?
Yeah, if we really suspect there is like we know the nature of the injury, so then we can go ahead and give the ozol injection. Even we have given the lot of ozol injections at the time of primary repair itself.
Okay.
Intracameral and intracameral antibiotics also has to be given at the end.
Yeah. Ozol, it's
That's
better
why-
to give ozol for all, no, madam, for to be on the safer
yeah,
side.
better to be
Intravitreal
safe.
ozol all.
Yeah. So that is what, because if patient has to be counseled very like in a proper way. Counseling is really very important, because most of them think like, okay, surgery is done, I'll be fine. So anything might happen at the later date.
Right.
Hello. Am I audible?
Yes, sir.
Hello.
Yeah, I just want to clarify regarding that B scan once. My
Yeah,
opinion, it is depends upon the wound and this thing. You can do a gentle B scan, just the
yeah, very
screening B
gentle.
scan
If it
to
is the
yeah,
corneal
very
tear is
gentle
very
B scan
small
can
or
be done depending
huh,
upon the size of the wound and
yeah,
all the things. If it
yeah.
is small and self-sealing, can be done. And most of the patients, very gentle B scan can be done to screen.
Hmm.
The integrity, eyeball integrity is maintained.
And if you are sure that there's no globe rupture anywhere else, sometimes it will be occurred. Then possibility that with gentle B scan you will come to know the inner structures. But that's what it all depends on clinical scenario, how exactly.
Each case depends upon each case.
Exactly.
I have one question for the previous speaker.
Yeah. Dr. Ponnappa.
Yeah,
Ponnappa?
yes, yes.
Do you prefer using MMC in
Yes.
mitomycin in combined procedure?
In everybody.
Or what precautions you take in combined procedure?
With mitomycin C, number one is once you're putting the pledges, I always count the pledges what I put in. Because when I take out, I have to take out that many pledges. If I'm putting 2 or 3, I have to be sure it's 2 or 3 and take it out. And then copiously irrigate, say about 3, 4, 5 times with your 5 ml syringes. And whenever you're holding, you change your forceps. Don't use that same forceps with which you're holding the mitomycin C and again hold the conjunctiva with that. You just, once you put mitomycin C, don't use that forceps, put it aside.
So these are universal precautions. Any other precautions if it is combined surgery?
Which one?
These are the universal precautions if you're using MMC, no?
Yeah, universal precautions we use that.
Any special precautions if you're combining with phaco and trab?
No, because I don't do single site at all. So I use twin sites. For phaco, I use temporal approach, and for my trab, I do superiorly. These are the things I do, at least. Or what I have been learned in, and you're doing it in Arvind. This is what we follow.
Hello.
I think, yeah. Manju, tell me.
Yeah, just quick questions for Madhu. It was a nice presentation. I just wanted to know when you want to do a corneal suture removal. And one more thing I just wanted to add, there is nothing called a gentle B scan. Okay. Whenever possible, you have to avoid a B scan as far as possible. One more thing, what you can do is you can do a intra-op indirect ophthalmoscopy so that you can just examine the posterior segment of the eye. Whenever you feel you can't do a pre-op evaluation. So there is nothing called
after the cataract surgery.
Correct. That is a preferred technique so that you can have a view of a retina, whatever to the possible extent, so that you can then later you can explain to the patient.
Yeah.
Okay. And just wanted to know when you want to plan a suture removal, like corneal sutures, after how many days, or like a selective suture removal you want to plan?
Yeah, usually if it is a very larger one like limbal to limbal, after 6 weeks we can do a selective suture removal, alternate. Or if it is very 1 or 2 sutures, we can go ahead and remove those sutures. But only thing is, scar has to be like wound has to be healed completely.
So usually it take around 8 weeks.
Yeah.
Okay. Fine. Thank you.
Okay, we'll go to our next talk. Next talk is by Dr. Manju, phaco-vitrectomy. Just to give you a brief idea about Manju, he's right now he's working at Ganesh Netralaya, Shirsi, Karnataka. Dr. Manju has done his undergraduation from Siddhartha Medical College, RGHS, and also fellowship from MM Joshi, Hubli. He's been successful vitreoretinal surgeon in Shirsi and around the areas. And also he has done many publications and presentations in state as well as national conferences. Manju, over to you. Ashwin, please play the video, please. Ashwin, play the video of phaco-vitrectomy by Dr. Manju.
At the outset, I would like to thank the organizers for